Good afternoon, everyone, and welcome. My name is Nadia Rosen. I'm the CEO of Head and Neck Cancer Australia. I'm delighted to welcome you to our webinar today, Keeping Your Teeth and Mouth Healthy After Head and Neck Cancer and the Different Roles of Dental Practitioners. I'd like to begin by acknowledging the lands of the Gadigal people of the Eora Nation. I also acknowledge the traditional custodians of the various lands on which you're all joining from today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people who may be joining us today. We're delighted to have you all joining us today. We have over 165 people registered from across the country and a few from overseas as well. The webinar will be recorded, so for people who weren't able to make it today, we'll be sending out the link to recording after the webinar. We're very grateful to have the support of the Jaye Radisich Foundation in Western Australia and the Dry July Foundation to be able to host our webinars. As a charity, we rely on donations and grants to be able to provide the free resources and education events that we do host, so we're very grateful for their support. And we obviously wouldn't be able to put these webinars on without our wonderful guest speakers. So I'd like to thank Dr. Amanda Phoon-Nguyen, Associate Professor Sharon Liberali and Jen Mackay. I'll be introducing them a little bit later. They'll all be on our panel and sharing you a little bit more about them. But before that, just a couple more housekeeping things. The webinar is interactive and we really do welcome your questions. There's a Q&A button at the bottom of your screen. So please put any questions you have in there and we'll do our best to answer them, although we do have a lot already. You're also welcome to text me on 0422 375 765 if you'd prefer to text to ask a question. Please note that we're unable to address individual cases, and if you do have a personal question, you should contact your cancer care team or Cancer Council Australia on 131120. And as I mentioned, the webinar will be recorded and will be shared on social media and on our website shortly after the event. As I was just saying to our guest speakers, I noticed that a number of people who are joining today are people that haven't attended one of our webinars or engaged with Head and Neck Cancer in the past, Head and Neck Cancer Australia in the past. So I just thought I'd start by giving everyone a bit of a brief summary of who we are and the resources that we've got available. So I'm just going to quickly share my screen. So Head and Neck Cancer Australia was launched in 2016. We're the only national charity in Australia supporting people who've been impacted by head and neck cancer. And we're dedicated to providing comprehensive evidence-based information and support to these people. The content on our website was developed over a 24-month period by over 70 head and neck cancer experts, as well as patients and carers from across Australia and New Zealand. And our content's reviewed every 3 years. We have a board that includes clinicians, as well as head and neck cancer patients and family members. And we have ambassadors that represent our community from across Australia. Our mission is very much dedicated to raising awareness of head and neck cancer and improving the outcomes of those people who are affected through education, information, support and advocacy. Our strategic priorities are to provide vital support to empower all patients and carers to better navigate their head and neck cancer journey by providing a central source of information and support. We also work really hard to raise awareness of head and neck cancer, to educate all Australians about head and neck cancer, to increase early diagnosis and encourage prevention. And in the last couple of years, we've been working really hard on influencing public policy, so engaging with government to advocate for policies and public sector funding that improve head and neck cancer prevention, early diagnosis and patient care. Head and neck cancer in Australia, just a bit of a snapshot. So there are over 5,300 people who are newly diagnosed with a type of head and neck cancer every year. And there are around 17,000 people who are living with head and neck cancer who were diagnosed in the last 5 years. There's no screening for head and neck cancer, so early detection is key. Survival rates in Indigenous Australians compared to non-Indigenous Australians, there's a 30% survival gap. Men are 3 times more likely to be diagnosed with a type of head and neck cancer, There's also been a significant increase in tongue cancers in young women in the last 30 years, despite the reduction in smoking. And I know that that's going to be talked about a little bit today. There's also been a significant increase in the number of people who've been diagnosed with human papillomavirus-related head and neck cancers. And 4 out of people will be exposed to the HPV virus at some point in their lives. So without screening, it's really important that people know the signs and symptoms of head and neck cancer and seek attention if they have any of the early risk factors. Why is head and neck cancer different? Well, it's not just one type of cancer. There are more than 10 different types, including mouth cancer, salivary gland cancer, throat cancer, skin cancer, and thyroid cancer. And treatment can affect critical functions, a person's ability to speak, swallow, eat, breathe, and result in facial disfigurements. It really does affect a person's identity, unlike any other cancer. The risk factors are smoking and alcohol use. But as mentioned, there's been an increase in HPV-related head and neck cancers over the last 20 to 30 years. And the incidence of oral cancers in young women, the cause for that's currently unknown. And obviously, the sun exposure is also a huge factor for skin cancers. Some of the challenges for head and neck cancer, as I mentioned, there are no screening tests, so early detection is key. There's not a lot of awareness about head and neck cancer in the general community. It's a complex cancer and navigation of the health system can be very difficult. Because treatment impacts a person's critical functions, it can have an enormous impact on a person's social, psychological, and working life. There are diverse outcomes and burden of disease. And while acute care is very good in Australia, the long-term side effects of treatment can increase over time, and there's very little survivorship support, particularly around dental issues, which can be lifelong. There's also a significant amount of stigma attached to head and neck cancer. We have a comprehensive library of resources on our website that are freely available for anyone to use, including information sheets on different types of head and neck cancer, as well as surgical procedures and health and wellbeing topics. There are animations, podcasts, recordings of our webinars. We also have the only directory of peer support groups in Australia and New Zealand. So it's a wealth of information. And if you haven't been on there, I'd encourage you to look. And we also send out free resources for people who are newly diagnosed. So you can certainly send us a request if you'd like any free resources. So that's just a quick snapshot before we start, for those of you who may not be aware of the work that we do at our charity. But now I'd like to introduce and really kick off the webinar, introducing our guest speakers. So today we're going to have a panel discussion. We're all going to be on screen for the whole webinar, and kindly Amanda has offered to host the Q&A session. So I'd just like to give you a brief background on all of our guest speakers. Dr. Amanda Phoon-Nguyen is an oral medicine specialist from Western Australia. Her clinical and research interests include orofacial pain, oral mucosal disorders, dental sleep medicine, and paediatric oral medicine, as well as temporomandibular disorders. Amanda completed her specialist training at the University of Western Australia, and her understanding of oral medicine became personal when a family member developed oral cancer. When Amanda completed her training, she was even more motivated to help others. She supports patients in her role as a clinician at the Perth Oral Medicine and Dental Sleep Centre, through her public appointment at the Oral Health Centre of Western Australia as an adjunct senior lecturer at the University of Western Australia, and as a consultant at the Perth Children's Hospital. Thanks, Amanda. Associate Professor Sharon Liberali completed her undergraduate dental degree at the University of Adelaide in 1986 and was awarded a Doctor of Clinical Dentistry and Special Needs Dentistry at the University of Adelaide in 2009. In 2010, she became a Fellow of the Royal Australasian College of Dental Surgeons in the special field of special needs dentistry. Sharon is the Director and Senior Consultant of the Special Needs Unit at the Adelaide Dental Hospital, South Australian Dental Service, and holds an Honorary Associate Dental Consultant position at the Royal Adelaide Hospital. Sharon is also the Program Director of the undergraduate and postgraduate programs of special needs dentistry at the Adelaide Dental School at the University of Adelaide, and currently sits on the ADA Federal Board. Sharon was awarded a Distinguished Service Award for her services to the dental profession from the Federal ADA in 2019. And last year in the King's Birthday Awards, she was awarded an Officer in the General Division of the Order of Australia for Distinguished Services to Special Needs Dentistry. Thank you very much, Sharon, for joining. And last but not least, Jen Mackay was a healthy and happy 44-year-old public servant when she was diagnosed with stage 3 tongue cancer in June 2022. Jen underwent major surgery to remove half of her tongue, followed by 35 rounds of radiotherapy and concurrent chemotherapy, finishing her treatment in October 2022. Jen is very much looking forward to sharing her experience of caring for her teeth and mouth during and after treatment to help others. Thank you all very much. Thank you for listening to the introductions, and I'm really pleased now to hand over to have us all on screen, if we can, and to hand over to Amanda, who's going to lead our Q&A today. Thanks, everyone.
Thank you. Thank you very much. So thank you everyone for joining us today, and thank you to the panel. I am happy to keep this very interactive. So if you do have questions, Nadia has spoken to you about either texting her or popping it up in the chat. We did receive quite a lot of questions already with the registration. So I don't know how many we'll get through, but we'll do our best. So the first question, actually, I've divided up this panel discussion into before the cancer diagnosis, during and then after. So that's how I think we'll sort of structure this. So one of the first questions I received was, who is actually at risk of head and neck cancer? And I thought it'd be really good for Jen to actually share her story, because I think it's quite pertinent. Jen, would you like to speak to that?
Yeah, sure. Basically, as Nadia said, I was relatively healthy. There was nothing particularly interesting about what was happening in my life at the time. I developed an ulcer on the side of my tongue. I assumed it was my tooth rubbing on my tongue causing the ulcer. So I took myself off to the dentist, who basically said that I needed a crown. Now, crown's obviously very expensive, and so I went off to think about that. And while I was thinking about that, the ulcer just got bigger and bigger. So I went to my doctor, and they prescribed me a course of antibiotics, which they said I was too young and I didn't meet the profile for it to be anything sinister, so to just go and get the crown. Now, I wanted a second opinion, so I went off to see my orthodontist, and they're the ones who referred me to a head and neck cancer, or an ENT, someone who could actually have a look. And as soon as I walked into that room and opened my mouth, they said that's SCC. So that's squamous cell carcinoma. Now, by then, the ulcer was 4.5 centimetres. So it was massive. In those 6 weeks between seeing that first dentist and seeing the ENT, it's a very aggressive cancer, so early intervention really is important. As soon as that happened, then I was basically booked in for major surgery. I had a neck dissection, so they took out the lymph nodes in my neck. I had half my tongue removed. They replaced it using tissue from my thigh. I had tracheostomy, obviously a feeding tube, because I was very, very swollen afterwards. And then I went on to, once I'd recovered from that enough, then I went through 35 radiotherapy sessions. I had quite high dose radiotherapy, up to 70 GY, and concurrent chemotherapy. So the treatment was relatively brutal, and it certainly has ongoing side effects. I was actually released from hospital this morning because I'm one of the unlucky ones who have developed osteoradionecrosis, and I had an infection in my jaw, so I'm a little bit swollen. So, please excuse that. And that's my story, Amanda. Thank you.
Thank you so much for sharing. I mean, I think one of the points that strikes me about your story is that head and neck cancer can affect everyone. So just because you're not of the typical population that head and neck cancer was seen in doesn't mean that you can't get it. So we know that traditionally head and neck cancer is seen more in males above 60 who have a big history of smoking and alcohol, but we know that that's increasing in the younger population. So Sharon, one of the questions that I received was, why is the oral cancer rate increasing among younger people? Is that something that you're seeing more in your practice as well?
Yeah, absolutely, Amanda. You know, the ages are getting younger and younger, and as Nadia alluded to, we're seeing more females with oral cancers as well. And historically, in the 80s and 90s, when I was looking after these patients, they were elderly men, high alcohol, high smoking histories. But a lot of it is to do with these HPV squamous cell carcinomas, which, as you know, predominantly occur in the tonsil and base of tongue. One of the challenges with them is that the primary cancers are often very small, and people don't often present until they get the lymph nodes coming up in their neck. So we are certainly seeing younger patients presenting them, not necessarily with smoking histories or large smoking histories, not necessarily with alcohol histories either. And so, you know, one of the things that we saw with Jen was that, you know, she went to see her dentist and her dentist thought it was traumatic, but didn't actually, and correct me, Jen, if I'm wrong, recommended a treatment, but didn't recommend she come back in a couple of weeks' time and follow up on that ulcer. And I'm sure you as an oral medicine specialist would agree that's one of the first things that we do. We try and find the cause if we feel it's traumatic, and then follow it up by ensuring we can either address the cause and ensure that the ulcer resolves. And if it doesn't, then our suspicion should be heightened that there's something more going on here, irrespective of the age or the gender of the patient.
One of the things that also strikes me from your story, Jen, and it is something that I see more often than I would like, where there is a delayed diagnosis because the patient has been given antibiotics for an ulcer or something like that. And as Sharon said, there is no sort of checking whether the lesion has healed or any sort of follow-up. I mean, first of all, I'm not sure antibiotics is always indicated for an oral ulcer, but what are, because we have quite a good mix of patients and health professionals on this webinar, what are some of the red flags, Sharon, that we should that they should be aware of? So I think the first one that we've already discussed is anything that doesn't heal up in a timely period, say 2 weeks or so. But any other red flags that you would like to highlight?
Yeah, I guess if the presentation changes as well. I mean, one of the things I like to do is have a feel of the ulcer and feel how, you know, what the tissues feel like. And if there's hardened areas there, if it bleeds spontaneously, to me, they're always red flags. If it changes in its appearance, if it becomes much more erythroplakic, then I start to get worried as well too. So, you know, they're sort of, for me, the main red flags around, and that's why I like to see the patients, you know, 2 weeks time, or and if I'm still a bit suspicious that I'm overreacting, I'll see them again in 2 weeks later, in 4 weeks time. So I am actually monitoring those patients really closely. I guess the other thing is too, you know, if you've thought that it's perhaps traumatic in origin, and you try and identify the cause. You know, Jen was told that she needed a crown, but, you know, is there a sharp cusp there? Often I'll get referrals from ENT surgeons saying, this patient's got a history of regular odontogenic trauma, so I'll be looking for sharp cusps, broken teeth, things like that, where you can fix up really easily as well, and then see whether the ulcer resolves. The other thing I'm really always cautious about is, you know, is there another reason for the ulcer, like a viral reason? So if I think there's something there, I might swab that area as well to see if there's an underlying issue, and look for virus and sometimes even fungal issues as well. So I'm sort of casting the net wide to look at all the potential things that could possibly be causing that ulcer.
And we've framed this question around an oral ulcer because that's what you developed first, Jen, but there are other things as well. So for example, if a dental professional has done a procedure, so say if they've taken a tooth out or if they've done something and the area is not healing as expected, that should definitely be followed up. We do show caution with localized pigmented lesions as well, any sort of facial swellings or anything that's unusual. And in an ideal and perfect world, when you go and see a healthcare professional, they would be able to pick it up, they recognize the red flags and things like that. But of course, things don't always happen that way. One of the things that I think was a really good point to highlight from your story, Jen, was that you did seek a second opinion. You knew it wasn't quite right, it wasn't healing, and then you found someone who was able to help you. One of the things that we would like to streamline for people that are listening is, if you have someone who has something that is not healing in your mouth, who do you see and what do you do? And Sharon and I have sort of discussed this a little bit. It is a little bit tricky because I think it depends on what state you are in as to what sort of access to specialists that you have. But how would you like to break this down, Sharon? Like who should someone see if they suspect that they have something that could potentially be cancerous?
So I think, as you know, dental practitioners, if we see a patient that we're concerned about, I'd be referring them. Unfortunately, I don't have the luxury of an oral medicine specialist in South Australia, but certainly either an oral medicine specialist or an oral and maxillofacial surgeon for advice. I think the other thing too, really importantly, as dental practitioners, don't just send the referral and not follow it up. If you're really concerned, bring up the practice and say, I've got this patient, I'd like, Dr. So-and-so to see them. I'm really concerned they've had an ulcer for 2 or 3 weeks. You talked about the fact, Amanda, that delay is often the biggest problem for patients, and it can impact on their prognosis as well. Jen was talking about the fact that, she was put on antibiotics. Well, that's another week delay. And I've had several patients that have been put on antibiotics, 2, 3, 4 times, and then they've sent a referral off to an ENT. So I think as dental practitioners, I certainly would prefer an oral medicine or an oral and maxillofacial surgeon. If you don't have one of those readily available, then certainly a GP, and then ask for a referral to an ENT surgeon in the area or a plastic surgeon. Unfortunately, as dental practitioners, if we refer patients directly to a medical specialist, the patient doesn't get their consult covered by Medicare. So that's a bit of a barrier for us. So that's why I'm saying go through the GP, but make sure you speak to the GP. Make sure your patient knows to speak to their GP and follow up on the referral, etc. If you're so inclined, and Amanda, I'd like your opinion on this about whether people should do their own biopsies. I'm a little bit concerned about that for 2 reasons. The biggest reason I find is that if you do get a positive result, you then need to tell the patient, and you need to have a clear pathway how you're going to refer that patient for ongoing care. You can't just tell a patient they've got a squamous cell carcinoma and not follow up with support that they need around that. So I'd really appreciate your opinion on that, Amanda, about whether people should biopsy or not.
So my personal view is that I don't think dentists should be doing biopsies. I know some people do, but in my opinion, the biopsy is not actually the difficult part, which is the surgical part of taking a small sample and sending it for testing. Because, most of us, we were trained in, minor surgical skills. The issue, as Sharon has said, is knowing what site to biopsy, because sometimes if you don't biopsy the right site, you don't get the right result. Knowing how to correlate the histopathology, which is what the pathologist sees under the microscope, and what the clinical presentation is, and then knowing what to do with the results. Because in this case, obviously, we're talking about cancer, but what if it's an oral mucosa condition or any of the things it could be? Like, would someone know what to do with the biopsy results? So I would concur with your advice, which is that if you think it is potentially serious, please pick up the phone and call whoever you're referring to, because there are long wait lists of specialists in most places, but most specialists also have a triage process where if something is urgent, you will get in a lot sooner. But the only way that they will know it's urgent is for the referring person to actually highlight to the specialist, take photographs. It is so helpful if you send referrals with photographs as well, so we can see what we're looking at. So I think that is extremely important. And then from the patient's perspective, if you think it's not right, if you're being given repeated antibiotics, which is also something that I see, seek a second opinion and ask for a referral to a specialist, because early detection is key. I saw Alice's question about post-treatment. So we'll come to that in the post-treatment section of what we talk about after someone has been managed for head and neck cancer. Let's talk about the time period when someone gets diagnosed with oral cancer then. So is it important that you see a dentist when you are diagnosed with oral cancer? So say you're about to have surgery, start chemotherapy, start radiotherapy. Is it important that you see a dentist around the same time? And then we can discuss this. But Jen, did you see a dentist at the time that you were about to have treatment?
Well, I was a regular attendee at dentists, so basically my teeth were in pretty good nick, and the surgical team were able to tell me that. So they basically said, have a look at my teeth, and I was with maxillofacial, And so they were able to have a look at my teeth and say, no, they all look good. And so in that respect, I was lucky. I know a lot of people who have had head and neck cancer treatment and have had to go through and get, things like teeth removed before radiotherapy, and have some more, preemptive work before they go down the surgical path. But again, I'm no expert at that part, so I'll divert to you guys.
Yeah, no, all good. Because I mean, part of the reason why we want patients to see a dentist before commencing dental treatment is that um, there are there sometimes can be work that needs to be done before starting treatment in case there is infection, and there are long-term, adverse effects of some of these treatment as well. So so one of the things that Sharon and I have discussed previously is whether patients always need teeth removed, because a while ago there was a more of a stance where patients will get teeth removed to prevent problems from happening to them in future. But Sharon and I both agree that that's not really what we would recommend anymore. So let's have a little bit of a chat about it, Sharon. So why would someone need teeth extracted before head and neck cancer treatment, and what teeth really need to be removed?
I guess it depends on whether they're having radiotherapy or radiotherapy and chemotherapy. That's how I make the assessment. The other thing I think about is the patient's sort of dental history. Jen talked about that she was a regular dental attender. I can get patients from Jen's sort of experience right back. I think the winner for me was someone who hadn't seen a dentist for over 50 years. Now, one of the key things after head and neck cancer treatment is that they will need to become a regular dental attender if they want to keep their teeth into the longer term, because then we'll talk a bit about some of those risks. So when I make an assessment, it's actually about, okay, what's their oral health status like now? Are they, if they haven't been regular attenders in the past, are they willing to change that so that they will become regular attenders? And talk to them about some of the risks that they will have ongoing to then help me in my treatment planning. The reasons for extractions, as I said, sometimes it's whether they're having chemotherapy or radiotherapy. If they're having radiotherapy, I think about the long-term impacts that they are going to have to deal with after radiotherapy to maintain good oral health. We know after radiotherapy, patients are going to be at a much higher risk of dental decay because of the changes to their saliva, perhaps changes to their diet, and also changes to the oral clearance. When we don't have good saliva, the natural oral cleansing isn't as good. We need to rely on much better daily oral hygiene and more preventive processes, etc. So if the teeth are, well cared for, the patient's well motivated, then I'll be really very less inclined to take any teeth out. If the patient has, heavily restored teeth, lots of periodontal disease, isn't really motivated to maintain their teeth, or, doesn't want to go regularly to the dentist, then I'll talk to them about the risk-benefit analysis that I go through in thinking about which teeth need to come out and which teeth need to be saved, or treated or maintained into the longer term. The other side of it from radiotherapy is your timing as well. So we're very lucky in South Australia, we have excellent relationships with our multidisciplinary team. So we like to see the patients ideally before surgery, but definitely, in that immediate post-surgery period, so we can assess them, because I want to have ideally 21 days, if I'm going to take teeth out, between extraction and healing, to allow for healing before they start radiotherapy. So that's the other factor for me. Am I going to have enough time to get the teeth treated, the teeth extracted, and sufficient healing time before the patient starts radiotherapy? If I'm not, then I'll leave those extractions for the immediate post-radiotherapy period, and we'll talk about why in a moment. If it's chemotherapy and radiotherapy, then the other assessment I'm making is what is the risk the patient's going to end up with an odontogenic infection in the middle of their treatment, because as a result of the chemotherapy, they may become neutropenic. So their white blood cells and their neutrophils in particular will reduce. The impacts on our immune system are such that the normal immune response doesn't occur, and they're more likely then to get either a localized or even worse, a systemic infection from a dental cause. And that's the other thing I'm thinking of if they're having chemotherapy as well. So in those sort of situations, if I can do root canal treatment, if I can manage the at-risk periodontal infection, the teeth will remain. Otherwise, I'm talking to the patient about taking the teeth out. But I really don't like to take them out, so I try and maintain them at all costs. But it really depends on the patient's motivation. And the other thing, of course, is their access to care. You know, some of our patients that we'll see will be in rural and remote areas where easy access to dental care can be challenging as well. And that may be another factor to consider.
Yeah, so my philosophy is very similar to yours as well. I don't like taking teeth out, or for me, I don't like recommending that teeth be taken out unless we absolutely have to. And I think it's very important to look at the patient's motivations, because we know a lot of these side effects can be long term, like these lack of saliva and things like that. So we do take that into account. But I do think that on the whole, we are moving away from taking teeth out to prevent things happening to them in the future. And we're more about, educating and motivating the patient so they can take care of what teeth they have long term. So on the whole, the teeth that I would recommend be extracted are teeth that are hopeless in most cases. So basically they cannot be saved and they are going to be an issue. And then everything else is kind of on a risk benefit analysis, like Sharon said. So one of the questions that we have is, what questions should I ask the cancer team before treatment, so with relevance to oral health? I think it is quite reasonable to ask your cancer team or your dentist or whoever's on that team about the treatment plan that they have for you, because I do appreciate it when patients talk to me and ask me about why I've recommended this and why I've recommended that. So I would like to empower the patients to know that they can ask questions around that. Now, let's talk about the short-term side effects of head and neck cancer treatment before going on to the long-term side effects. So the shorter-term side effects, and we'll come to mucositis in a bit because I know you've published a lot on that, Sharon, but let's talk about some potential infections that can occur during the cancer treatment, because there's a lot going on. As Sharon said, your health changes, your mouth is dry, you're not eating, or it's difficult to eat properly. So let's talk about some of the potential infections that can happen. And one of the ones that I do see being treated or preventively treated is oral candidosis, which is otherwise known as thrush. Now, one of the questions that we received is, what do we do to manage thrush when Nilstat oral drops and Dectarin oral gel isn't helping? Now, one of the things that I would like to highlight is to whether it actually is oral thrush that is being treated or not, because just from my experience, and I think from Sharon's experience as well, is that a lot of times we see people being treated for thrush when they don't actually have thrush. So during cancer treatment, your mouth will be dry, there'll be more debris, there'll be more sloughing. So it's not unusual for there to be mucosal changes in your mouth, and there can be little white areas that can be mistaken for thrush. So if you do have an active thrush infection, well, if you're not sure if you have actually a thrush infection, make sure it is diagnosed properly. People may do things like swabs or, like a experienced clinical examination. One of the things that I did mention to the panel that I would like to highlight is I don't feel that Nilstat oral drops should be first-line therapy for a oral fungal infection. And I know that it is very popular. The reason for that is that Nilstat oral drops, looking at the studies, is about 50% sugar. We know that dental decay is a big problem for people who have head and neck cancer because they're at much higher risk due to their diet changes and their saliva changes and, lack of clearance with the tongue and things like that, depending on what their management was. If you are constantly using something that is 50% sugar and you're constantly applying it to your mouth, we know that your rate of getting dental decay is much higher. So I've had patients who've come in to see me, they're doing everything right, they're keeping to a low sugar diet, they're cleaning their teeth with a high fluoride toothpaste, they're maintaining their teeth very well, they see the dentist regularly, but they are getting what we call ringbark caries. So basically it's caries all around the teeth and they don't understand why. And then we have a look at their medication, and it's because they've been using Nilstat to prevent oral candidosis and they're applying it in their mouth all the time. The studies also do show that Nilstat is the least effective antifungal. So I would encourage to consider other antifungals. And there is Dectarin oral gel, which is miconazole oral gel, a few interactions that health professionals can look up on. But Dectarin oral gel does tend to be accessible. It's inexpensive, and it's relatively easy to use as well because it's gel. Fungulin lozenges is another antifungal that is available in Australia, which is a lozenge that you suck on. Takes about 30 minutes for it to dissolve. It can be difficult for a head and neck cancer patient to use this because to suck on a lozenge, it can be a little bit rough. It can irritate the mouth. Sometimes if a patient can't use miconazole oral gel, they can use Fungulin lozenges, but they can sort of pre-dilute it a little bit, so mix it up so it becomes more of a slurry rather than a lozenge. But I would consider, I would encourage that if you are routinely recommending that every patient use Nilstat oral drops, that you do consider the efficacy of the Nilstat and also the fact that it can actually, well, it will predispose your patients to getting more dental caries if you're using it longer term. Sorry, I think I went on a bit of a rant there. Sharon, what do you what do you think?
Yeah, I guess, I'm a big fan of preventive rather than therapeutic options. So I often talk to my patients about preventing thrush. So I bring it right up in the front. So one of the first things I talk to them about. One of the ways I found is really, really effective is we know that thrush or fungal organisms will overgrow in an acidic, sticky, tacky environment. So let's try and get rid of that environment. All right. So I get them to do bicarb soda rinses on a regular basis. We're moving then out of the acidic into the alkaline or the neutral air, which the fungal organisms don't like. The bicarb has a bit of aerosolization to it, so it'll get rid of some of that tackiness that's in their mouth. And then I get them to have natural yogurt. And we know that putting good bacteria in will actually prevent thrush as well, because thrush is an overgrowth of fungal organisms. So I get my patients to do that right from the start. I get them to do it 3 times a day to try and create an environment that the fungal organisms don't like to live in. Candida doesn't like that environment. If they do get thrush, and if they come to me and they're on Nilstat, I try and get them off of it, because one is someone else has made a decision that they've got thrush when, as you said, much of the time they haven't. And then I like to see how that resolves when we just put them on those alternate therapies. If they have to be on Nilstat, and because they can't take, say, Dactarum because of the azole interactions, then I'll keep them on Nilstat, but I'll monitor them really closely around those risk of the caries. And the biggest problem I see is actually not the ringbark caries. I see it very early on when you're getting that really early, we call it demineralization as practitioners, when the teeth lose that lovely glossy appearance and they get that chalky appearance, and sometimes even the enamel will just flake off, which is even worse. So I try and keep a very close eye on them. After they finish treatment, sometimes the doctors also like to keep them on the Nilstat, for weeks and weeks afterwards. I try and get them off and get them to try and get rid of some of that debris that you were talking about off. And particularly the biggest problem is often on the top, or we call it the dorsal surface of the tongue. And tongue scrapers, you can get a really nice soft tongue scraper to remove some of that debris. The patients rinse their mouth regularly and brush, even if 3 times a day, if you can get them to do that, to get rid of all that debris out of their mouth. I often find that works really effectively to reduce that risk of thrush. Jen, as a patient, have you had issues with thrush, and how have you found that it's worked for you?
Yeah, I must admit, I was in a position where they were giving me Nilstatin as a preventative measure while I was going through the radiotherapy. So I did what I was told. I wasn't aware of the sugar content. However, I did stop it when radiotherapy stopped, and I haven't used it since. I have used the Phoon-Nguyen lozenges, but because my mouth was already really quite dry, I found that it was like sucking on chalk, which is absolutely hopeless for someone with limited saliva. And so I stopped that. But again, it may have been more, my tongue doesn't hit the top of my mouth, which means I don't get much of that. The stuff doesn't clear off it very easily, which is why I use the tongue scrapers, either the brush or the little metal, versions, just to clear it off. But I did have, a couple of times where I was diagnosed with thrush as well, but it cleared up again with some, minor treatments and, lots of yogurt and stuff like that too. So, yeah, that's what I recommend.
There are plastic tongue scrapers available as well, which are much nicer than the rake you're using as well, Jen. And so I tend to give those to my patients. And the other thing is fungal and lozenges are not very nice when you've got a mouthful of mucositis. That's That's the other thing. So, you know, I always say, don't have a one size fits all. Look at what your patient has, look at what they need, and then go from there. I guess the other thing to be careful of, Amanda, is I'm always looking to see where the thrush goes. So if it's going down the back of the throat, then I'm speaking to my medical colleagues about some systemic antifungals. I don't want fungal infections in the lungs for my patients. And so, you know, as dentists, we are limited, or dentist practitioners, we're limited looking oral thrush. But if you're starting to see oropharyngeal thrush, you have a much heightened sense of, well, certainly I have a heightened sense of anxiety about getting on top of that.
Oh, yeah, agree. Yeah, definitely. Now, just to clarify, if you have been prescribed Nilstat oral drops by your oral oncology team, don't stop taking the Nilstat oral drops because of what we said. Please clarify with your team, okay? So this is just generic type advice. The other thing as well that you've that came to mind when you were speaking, Sharon, is in patients who are wearing dentures. So one of the things that a dental professional can do and a patient can do first up, if you're worried that you're at risk of getting an oral thrush infection, which patients who are wearing dentures will be, is to improve your denture hygiene. Don't wear them to sleep at night. Take them out, give them a good clean with a soft brush and soap. And I tell my patients to leave it out dry overnight, give it a good rinse and pop it in the morning. So things like this will be really important if you are wearing an appliance. We've had a couple of questions. So maybe let's talk about some products now, because these are questions around products. So Veronica has asked, do you have success with patients using ACP products rather than high fluoride toothpaste with dry mouth and decalcification issues? So with the ACP products, my understanding with those products is that you need saliva for those products to actually work. And one of the biggest issues in patients who have head and neck cancer radio treatment is that their salivary gland hypofunction does tend to be longer term. So my preference is actually for patients to use high fluoride toothpaste twice a day. Yes, what do you think, Sharon?
Again, I don't have a sort of one size fits all, Amanda. I'm a big believer in saliva testing. So I undertake saliva testing at different stages. I normally do it at about 2 months post radiation, then 6 months, and then 12 months. And I allow the testing of the saliva, both in terms of quality and quantity, to guide me. ACP, CCP, or tooth mousse does have a role. And sometimes it's more than just the prevention of decay. It can actually be really quite soothing to patients to put it on in the night time when their mouth's really, really dry, when they wake up and Jen's tongue won't touch the roof of her mouth, she tells us, but, you know, there's nothing worse than waking up to your tongue stuck to your palate. So I will tend to use high fluoride products if I feel there's a reason to do that. And so often we'll combine the two as well. For some of my patients, Jen talked about the fact that she had chemotherapy with 70 gray of radiation, which is the higher end of the radiation exposure that patients with head and neck cancer will get. Most of the time, and I bet Jen will concur with this, if you've had an oral tongue cancer and you've had 70 gray and bilateral radiotherapy, so both sides and chemotherapy, you have no saliva after that. And so I find that those patients, I almost can't even do a saliva test because there's nothing to test. And I'll put them on either Nutrifleur 5000 or ClinPro 5000 twice a day, and we'll often add CCP, ACP to that, or tooth mousse, because we know the absorption of fluoride is limited by the presence of calcium and phosphate. And to have saliva, we know saliva is a reservoir of calcium and phosphate for reabsorption of tooth structure or the minerals. And so often I'll mix the two together. So I'll get them to brush twice daily and use the CCP, ACP in the night time. So I don't sort of have a set protocol. Some of my patients, I'll just get them to use the Nutrifleur 5000 or the ClinPro 5000 or the higher fluoridated toothpaste once a day, some of them every alternate day, really depending on how much stimulated their saliva they're producing, what their diet's like. And we know some of our patients will be on nutritional supplements afterwards. And some of those nutritional supplements, if they're fruit-based, will actually have a lot of sugar in them as well. So then I'm starting to think about, okay, what do I need to do for that patient to educate them about how they manage that. They need to have their nutritional supplements, but if they're going to have it and it's in a form of a sticky solution, they need to be rinsing that off afterwards so that we don't have that sticky solution. So I guess, Amanda, mine is very much tailored to how the patient presents to me and how they progress through that post-radiation period as well.
That's actually interesting because one of the questions here is how does diet affect teeth? And the dentist and the dietitian is actually saying different things, which is something that I see quite commonly. Because if you're losing weight when you get when you have head and neck cancer treatment, you are put on supplements to keep your weight up. Unfortunately, these supplements do tend to be high in sugar. They do tend to be sticky and they can cause dental decay. So your dentist will be telling you, try to like brush your teeth and everything. And the dietitian is trying to keep you on all of these supplements. So I can understand how sometimes it can be confusing, especially for the patient. I mean, one of the things that I would recommend, as Sharon said, is that, having really good oral hygiene to make sure that, all of these sticky, sugary substances are not sticking to your teeth. We have had a few patients who had really bad dental decay, or they were getting really high rates of dental decay. And I think the dietitian considered them on diabetic formulas of these supplements, so they're not getting dental decay as badly. So yeah, I can definitely understand how it can be quite confusing, especially if you're getting symptoms and all you really want is like ice cream and custard as well. Well, let's answer
Amanda,
a couple more.
can I
Yeah.
add one other thing to that? So the other thing that happens often in the post-radiotherapy period is patients can't sit down to a whole meal.
Yeah.
They won't have breakfast, lunch and dinner. They'll be more or less grazing during the course of the day. And as clinicians, we need to find that out as dental practitioners, because then we need to tailor their guidance to how they're eating. I always say to patients, I want you to have a good diet. I want you to maintain your weight. And I have to work out the oral hygiene regime around that. And the other thing is you want them to have some quality of life. So if you want ice cream, have ice cream. Just let me know what you're doing so I can tailor your oral hygiene regime to that.
That's it. So having things in like in rather than grazing all day on sugary things, if you're gonna have the ice cream, sit down and eat the ice cream in one go. Rather than having a spoonful, every few minutes, every couple of hours. Someone's asked where we can recommend that they get a soft tongue scraper or brush, or where to source. You can get them pretty easily at Chemist Warehouse in your local pharmacy. I don't think they've been particularly hard to find, at least in Western Australia. Yeah. Jen, you got yours pretty easily?
Yeah, I think this one was from a $2 shop, so it's
Find them,
probably a bit more than $2 nowadays, but it still works.
Just make sure the bristles are soft.
Yeah.
And like I said, Jen's metal one looked like a rake to me. So
Yeah.
I tend to use the ones I tend to give my patients. There's Curaprox put out a beautiful, soft, very similar to your scraper, Jen. It's just soft. It's got and so I think that's the key, really. It just needs to be, and you don't need to be really scraping it down. You just need to be very gentle to remove the buildup off there.
Yes, yeah, because if you scrape your tongue too hard, say with like a metal one, sometimes that can happen. You can actually get keratosis of the tongue, which is where you start to get white patches because you scrape too hard, and then someone might think that you've got thrush. All right, so another question. So for patients that are nil by mouth due to swallowing or safety concerns, what do you suggest as the best oral thrush prevention and or treatment plan? My experience with this is that actually patients that are nil by mouth, I actually find that they've been misdiagnosed with oral thrush more commonly than they've actually presented with oral thrush, because if they're nil by mouth, you get dried saliva, you get a lot more debris, where the mouth can actually look very different from normal. I mean, I think if a patient's nil by mouth and they do have oral thrush, so if it has been diagnosed properly, I don't typically have an issue with Nilstat oral drops or Dectarin oral gel for the topicals. And then for systemics, obviously, that's probably best in conjunction with their oncology team. What do you think, Sharon?
Yeah, I agree. I think the other thing is just because they're nil by mouth doesn't mean they can't have sometimes a small bit of something. So for example, if they're nil by mouth, I'll still get them to swab with bicarb and clean out the around the tissues and the mucosa and the surface of the tongue. You can still put a small amount of yogurt on there, and just as a cream more than anything else. So I think you need to be careful around that. I agree with you. Most of the time when they're nil by mouth, it's not actually oral thrush. It's just debris that's collected there. And Jen will probably add to this, and it'd be good to get your opinion on this, Jen. Often when a tongue doesn't move in the same way, and you don't have the same volume of tongue that is a natural tongue, you will tend, and after surgery, there's often more grooves and things in that tongue as well. That's when you get debris in those areas. So cleaning that reconstructed surgical tongue is almost to some degree more important than cleaning a natural tongue, because of all those different grooves and things like that. Is that what your dentist told you, Jen?
Basically, yeah, I was recommended to use something to scrape my teeth down. I wasn't aware of the one that you've suggested, but I've written that down now. Just because I do get a build up on my tongue of basically whatever I've eaten or had to drink. If I've had a bit of jelly, I get like a coating on my tongue, because again, it doesn't touch the roof of my mouth. It doesn't reach my teeth. So, it doesn't get that normal cleaning process that most people would experience with their tongue. So it's kind of like a manual version of that.
The other thing to be careful of for you too, Jen, often when people's tongues won't reach their palate, I wonder whether you notice that you get more build up on the roof of your mouth as well, because that natural swallowing doesn't happen. That enables you to clear that. And so, cleaning the roof of your mouth becomes important as well. Otherwise, they see that debris on the roof of the mouth and think that's thrush as well.
Yeah. A lot of things are like peanut butter. When you've had peanut butter and you get it stuck to the roof of your mouth and can't move it. Well, most foods like that for me. So, but yeah, I completely agree.
So Liz has asked, would you therefore advise attending a dental specialist for xerostomia management long term? So my thoughts on this, I definitely do see patients for management of salivary gland hyperfunction, and sometimes xerostomia as well, longer term. So it's not something that is foreign to our specialty, special needs oral medicine. This is something that we would do quite often. But if it is something that is quite low grade, or the patient is managing well, my caveat is that they don't always have to see a specialist. So it's up to the dentist or dental professional referring them as to, because that's how we kind of work with referral pathways. If a dentist or dental professional feels very comfortable managing the patient, they're managing the patient well, and the patient is using appropriate products and stuff like that, and they're not getting very high rates of dental decay, they may not always necessarily need a specialist, but we definitely do see patients for this. Yeah. Sharon?
Yeah, I think we have to remember, we only have small numbers of special needs specialists and oral medicine specialists in Australia. We feel we're very important, but there's only small numbers of us. And I think, Amanda will tell you, and I'll tell you, I spent a lot of time lecturing both dental practitioners, training dentists, training oral health therapists, etc., on management of patients that have dry mouth or reduced salivary function. So I certainly don't think every patient needs to be referred to us. There may be patients where dentists want guidance or advice on some specific part. So often I'll see a patient for a consult for one aspect of it, but not across the board. I think the key things are, from a patient perspective or from a practitioner perspective, to have a really good understanding of what head and neck cancer therapy the patient went through. There's a big difference in salivary impairment for someone who's had bilateral radiotherapy and chemotherapy like Jen has, to someone who's just had unilateral radiotherapy. So again, not one size fits all. You have to really understand what the patient's treatment went through and included. And I think, there's lots of opportunities for dental practitioners to seek that advice where the patient doesn't necessarily have to be seen by them. With the ADA, we've got peer. There's amazing things that come up on peer, lots of different questions. I think this week there was one on Stelara, which is a particular drug that's used for people that have Crohn's. So, and we have, lots of opportunities. There's on the ADA platform, there's lectures that have been done, and Nadia talked about some information that's available on head and neck Cancer Australia too, to guide clinicians as well. So I think you don't really always need to send your patient to the clinician. Sometimes you can just seek out advice from one of your colleagues to guide you around that as well. There are a small proportion of the patients that really need input from people like Amanda and myself to try and get some guidance around that. And often I won't take all those patients on, and I'm sure you're the same, Amanda. You'll assess the patient, give some guidance, and then send the patient back to their general practitioner. I think it's really important as a profession we're able to manage these patients and care for these patients, but we do need to have an understanding of the treatment the patient's gone through.
Now, someone's asked about some of the products for xerostomia or dry mouth. Homemade bicarb solution or hospital bottled solution best? To be honest, I just do homemade. So I print out a little recipe and tell them how to do it. I don't really think you need to purchase a product. I think you can make it yourself. Yeah, same, Sharon. Yeah.
I have
and what are some of the...
sorry.
Oh, sorry, Jen. Yep.
Oh, I was going to say, I mean, there are a whole bunch of products out there that, you know, people have tried, because obviously out of desperation more than anything else. It's one area I love some more researching, so there's eventually a solution to it, because it is one of the most debilitating parts of the post-treatment experience. So at the moment, I mean, you can get things like the dry mouthwash. I personally find that doesn't do much, but some people swear by it. There's there's mouth gel. Again, I don't find that particularly helpful, but some people swear by it. There's some sprays you can get. Again, something I don't particularly find helpful. I find drinking a lot of water is probably the most important. But overnight, I do use these things. They're basically called Xylem Melt Dry Mouth, and they're little tiny kind of, you know, tablet things that you stick in the side of your gum, and it releases slowly. I wouldn't, it's not saliva, but it certainly, you know, helps you keep your mouth a little bit less dry overnight. If I don't use these, I'll wake up every half hour with a really dry mouth and have to have some water. But with these, I can last about an hour, 2 hours, depending. So I find them really helpful. But again, other people haven't. So it really is very individual.
Well, maybe because a lot of the products that we recommend or that I recommend are similar to what you have. So I've had fairly good results with the xylemounts, although the response can be mixed, because xylitol does have a dental decay preventing effect, the xylitol in there. So that's quite a nice one. And sometimes patients find it comfortable to have it and then fall asleep. So they're not struggling with that dry mouth aspect as much. I do always give my patients samples of the, the Oral 7 mouthwash, mouth gel, and mouth spray, because they can try it. You are right that it doesn't help everyone. And a lot of people are like, it's good for as long as it lasts in the mouth, which is a couple of minutes. But sometimes it's worth a try, because as you said, sometimes management of dry mouth is tricky, and there's a lot of it is products, because there are certain medications that we can give that will increase saliva, but there's a lot of side effects. So it's not something that we would routinely do. So a lot of it is trying the best product. One of the things I would recommend, if you are looking at some of the dry mouth gels, if possible, to check the pH of some of the gels, because some of the gels are actually quite acidic, which can cause teeth problems, but all of the ones that you've shown are fine. I think Dentamet's another one that's quite common in Victoria. That's a pretty good product as well. We can't get that as easily in WA, so we tend to use the Oral 7s.
I think the other thing too, Amanda, is, the pH is important. But think about the other products, other constituents in the products for the dental practitioners listening. I mean, I use and recommend Oral 7 a lot to my patients, and part of the reason I do that is the Oral 7 products have aloe vera in it, and often for a dry mouth there's burning that goes with that as well. That helps a little bit. The Oral 7 products have the lactoperioxidase system in it, which are some of the enzymes that are naturally found in saliva to coat the tissues, etc. And so also think about what you're trying to achieve with the products. The problem with the products, and Jen will agree with this, is they're expensive. They're not cheap, and they only give you symptomatic relief, often for a short period of time. And so, unfortunately, I always say to my patient, we don't realise how valuable saliva is until we don't have it. it is just not something that can be easily reproduced. And in my 30 years of practicing, none of the products have been equivalent to saliva, which is why most patients out of head and neck radiotherapy, you'll always see them carrying water bottles and sipping water all the time. Luckily, carrying water bottle is very trendy now, Jen. So, that's a positive. But they will find they'll get more symptom relief from sipping water constantly during the day than any products that you can get. The biggest problem is actually in the nighttime, because we know saliva production really drops in the nighttime. And that's when most patients will tell you they really struggle, because they'll wake up several times in the night, they'll need to get water, they'll go off and get a drink, then they'll be up again a couple of hours later going to the toilet. So I'll often say to my patients, just keep a little spray bottle with water by your bedside. When you wake up feeling dry in the middle of the night, give yourself a couple of sprays of water into your mouth, make sure your tongue and your palate get wet, and then try and go back to sleep. So you're not being woken up several times in the night between drinking and going to the toilet.
Very good. Now let's move on to mucositis, because that is something that will happen to probably a majority of patients depending on their dose of radiotherapy. Now, Jen, would you like to share your experience with mucositis?
Yeah, I mean, basically during radiotherapy, it was pretty horrendous. My saliva turned into a very thick, very limited function. It was neither pretty or useful. And so essentially, it just basically did nothing and made my life a lot harder. It was harder to swallow. It was really thick and sticky. And, that really didn't get better until probably a couple of months after radiotherapy. But even now, I can occasionally have those days where my saliva becomes quite thick and ropey. And, it's just one of the things that goes with the treatment, unfortunately.
Yeah, and Sharon, I know you've published quite a lot on mucositis, so I really feel for the patients that are going through that. It is one of the worst side effects, I think. The good thing is that it does tend to be transient, but I do understand that obviously when you're going through it, it feels like forever. What are some of the most helpful tips that you have for someone who is currently having mucositis, Sharon?
I guess the thing is I try and first educate patients about what mucositis is, where it should be presenting, because you know that if it's radiotherapy-related mucositis, it will only be in the areas where the tissues are irradiated. So if they're starting to get mucositis or ulceration in other areas, you really need to think about other reasons why they're getting why they're getting ulcers there. So that's one thing. I think the second thing is trying to manage the symptom. We know they're going to get it, trying to manage the symptoms and be ahead of those symptoms as well. One of the things I find very distressing for patients is when they don't have their pain relief appropriate. And so I'll often say to them, I like to try and see them at week 2, 4, and 6 during their radiotherapy. And I tell them what I'm seeing, whether it looks normal and what to expect next time, and what sort of pain relief they'll need. So usually for me, in the first couple of weeks, I'll be talking to them about something like Diflam mouth rinse or benzodiazepine. All the research shows that those anti-inflammatories are particularly beneficial for mucositis, because we know the first stage of mucositis is going to be inflammation of the mucosa. Benzodiazepine or the Diflam also has some analgesic impacts, and we know it's an antiseptic as well. So I tell them they get three bangs for their bucks with that particular medication. But we also know that Diflam or benzodiazepine has alcohol in it. So I tell them that they need to stop that by about the 2nd or 3rd week, because once they've got the mucositis, the ulceration and the alcohol content will start stinging. Sometimes a topical coating agent in the early stages of the mucositis will be beneficial. And I'll often talk to them about perhaps considering Mylanta or Gaviscon as a topical coating agent. But then I'll talk to them about, when they get to week 3 and week 4, sometimes a bit earlier, that if they're having concurrent chemotherapy, they'll need to have a topical anaesthetic agent. And we tend to use in Adelaide xylocaine viscous. Sometimes we use a solution called Pink Lady as well. And so they tend to work, they're just symptom management rather than anything else. But one of the biggest things I find is to make sure the patient's got their pain relief right. So you can, as clinicians, we can recommend that, but they need to speak to their radiation oncologist or their medical oncologist about getting their pain relief right. And you might speak more to that, Amanda, because you would probably tend to prescribe some of those sort of more systemic analgesics, which should be used, I think, and I talk to my patients about making sure they have it around the clock, not waiting till they get pain, but actually have a pain management program in place to manage the pain of the mucositis. And the other side of it is for them, I talk to them about trying to ensure that they can keep their oral hygiene as good as they can when that mucositis is present, so you then don't start getting an overlay of either bacterial or viral or fungal infections on top of the mucosa. And sometimes that means as they go into the 4th and 5th weeks of their treatment, that brushing becomes really difficult. They can't easily brush, it's too painful. And I'll talk to them about the use of chlorhexidine then to manage their oral hygiene when they're not able to brush.
And there's the little sponges, they have little mouthwash swabs and dabs. Oh, have you got some to show, Jen?
Yeah, that's one of them there.
Yes. Yeah,
The
to be
soda.
honest, at that sort of stage is just whatever you can manage as best as possible. Do you use a supersaturated calcium phosphate rinses like Cafasol and things like that?
Do we recommend that? No,
Mm.
not so much. Do you want to talk us through that?
Oh, so I had a colleague that told me that the pediatric hospitals were using Cafasol more, and it's pretty much like a coating agent, and that's something that we've tried because it's comforting. I don't know if I think the evidence is a little bit mixed. So I was sort of thinking about whether other cancer centers were using this supersaturated rinse or not, especially in the pediatric population. But it might be something that I'll look into a little bit more.
It
So we're
might be
running out of time. Oh, sorry.
Oh, I was just going to say, it might be similar to the Mylantra and Gaviscon because they're calcium agents as well.
Yeah, exactly. So I was just thinking
The
maybe it
same
was
mechanism.
difficult. Maybe it was difficult to get Cafasol approved through the hospital system. We might look at Mylanta and Gaviscon. So I'm aware that we're running out of time. So we're going to move now to long-term management, so post-treatment. So Jen, have you got any suggestions for how a patient can look for a local support group in their area?
Yeah, absolutely. My multidisciplinary team recommended our local support group, which was set up a couple of years ago, by one of the speech pathologists who's probably online actually, and one of the patients. But I know that there are quite a lot of them across Australia, and Head and Neck Cancer Australia on their website has a really good list of all of the ones that are local to each area. And I mean, I get a lot out of it. I think it's really helpful to talk about what everyone's been through and what they're continuing to go through, given the side effects keep going. There's not many people you can whinge to about, your limited diet and stuff like that who will understand, but your local support group, they will understand because they've all been through something similar. The interesting part about my local support group is I think pretty much every single one of us have a different type of head and neck cancer. There's a couple of other tongue cancer people in there, but there's, basically all of the head and neck cancers are covered in my support group, and probably that's reflective of the ones across the rest of Australia.
It would probably be remiss of me not to spend some time talking about osteoradionecrosis, Jen, given that you've just been discharged from hospital this morning for osteoradionecrosis.
Yeah.
I think, did you want to share anything about it? How were you diagnosed with it? It was infected?
So basically, basically a bone appeared in my mouth. I could see something, and I actually thought it was teeth because I didn't know any better. I thought maybe they'd left some teeth in there where they'd removed, 3 of my teeth, but unfortunately that wasn't the case, and I had a bit of exposed bone. That happened in September, and since then, because obviously with osteoradionecrosis, you have an open wound in your mouth, and the mouth is not the cleanest place, full of bacteria, full of everything else that I've had, numerous infections over the last 3 or 4 months, and this one landed me in hospital for IV antibiotics just to try to get on top of it, which is why I'm so swollen on one side. On the whole, it really only affects, as far as I know, from what I've been told in my research into it, it's about 6% people have been through radiotherapy, but that goes up depending on the, level of radiotherapy. And because mine was, up to 70 GY in some of the areas around my mouth, that, I was probably more likely to get it than that 5 to 6%. So basically, it's just very unlucky. It does mean my oral hygiene routine is incredibly important. So, I have to make sure that after every meal I'm using the little brushes and things like that to make sure I floss. And then I'm using I have to use an antiseptic mouthwash at the moment, which I don't recommend if you don't have to use it because it makes your teeth go brown. But, that's one of the other things that I have to do now because of that ORN.
Gosh, well, I'm glad that you're feeling better. I mean, I'm happy about that.
Happy to be home.
Mm. Now, one of the questions that we had was, is there a special type of dentist a head and neck cancer patient should see long term? And how do they find a dentist that has experience in this? Now, most dentists should have some level of understanding of the head and neck cancer disease because they're basically all taught it in dental school. But perhaps the best thing to do would be to speak to your oral oncology team or your head and neck cancer team or your local special needs or oral medicine specialist if they know any dentists in the area that have a special interest in this. What do you think, Sharon? I think that was something you would recommend.
I think one of the things we try and do here in South Australia is that if we're caring for patients and we get really apart from one's part of the state and metropolitan area, we get most of them in South Australia being a smaller state. But perhaps if you can liaise with a head and neck cancer dentist that was part of the multidisciplinary team, so you can get really specific information around what sort of treatment was given to the patient. Because, like I said before, if they've just had radiotherapy to one side, if they've had lower dose radiation. So, for example, if the patient's had lymphoma, they're not only going to have 35 to 40 gray. That's going to be a completely different situation to someone like Jen. So reach out to the dentist, find out where the patient's had the cancer treatment done, find out if there was a dentist as part of that multidisciplinary team that can guide you. So I always send a letter back to the general dentist that's looking after the patient and say, this is what your patient had done, this is what they were exposed to, these are the risks for your patient, and always put down that, they are never to extract teeth in the site where the radiation was, and talk to them about what osteoradionecrosis is and what the risk factors are. So if you don't have that information from the dentist that was part of that MDT, as a practitioner, reach out to that multidisciplinary team or that head and neck cancer centre and see if you can get some of that information from the dentist that's part of that team. Unfortunately, not all head and neck cancer centres, to my knowledge, have a dentist. And so therefore you may be able to reach out to your oral medicine specialist or your special needs specialist or a general dentist that's had some experience and knowledge around head and neck cancer management to give you some guidance. And I think that's important. One of the things that we know is with time, I always say radiotherapy is the gift that keeps giving. We know it's going to, with time, there's going to be other things, and those complications and complexities can compound. One of the biggest problems I'm seeing that's happening is this, what Jen had with the osteoradionecrosis. We know in the immediate period post-radiotherapy that patients are really good at telling dentists that they've had radiotherapy, but 2, 5, 10, 20 years down the track, they forget, and I can understand why. They want to put that all behind them, so they don't necessarily tell dentists they've had radiotherapy and a tooth may be extracted in the radiation site. The other thing I had earlier this week was a lady who had radiotherapy, and I looked after her 15 years ago. She's now been put on a bone-altering treatment for osteoporosis, and then you compound it. So I think if you're unsure, reach out to a clinician that can help you, guide you around some of these complexities. Because one of the bonuses we're seeing with head and neck cancer is that people are living a long time out of the treatment. The treatments are very effective. unfortunately, the treatments carry a lot of side effects, and people are living with those side effects longer into old age. And then, of course, we see the compounding issues. And Amanda, I don't know that you pick up a handpiece very often, but I do, and I have to try and do the dentistry, and that becomes quite challenging for me and importantly, the patients.
Before I pass this on to Nadia to close the meeting, probably one of the tips that I would like to share with patients that have a head and neck radiotherapy is to write down somewhere in your folder what dose you had and the region that you had, because that is something that you're going to have to give to every dentist. And lots of times people can't remember if the hospital has shut down or the department has moved. You can't really get those records very easily. So write that down. All right, I'll pass on to Nadia.
That's great advice. Thanks, Amanda. That was an amazing hour. We could have added another 15, 20 minutes, I think. That was fantastic, invaluable information and advice, and a special thanks especially to Jen, who literally just got out of hospital this morning. We're really, really grateful, Jen, for you sharing your experience. And I know, you know, your goal is to make sure that other people don't go through the same experience that you've had, and that they get detected early and get treatment early. So really grateful to you for helping, you know, raise awareness. I will be adding to, when we send around the recording, the link, I'll add a few links to some education modules. One is an educational module that we released last year in conjunction with the RACGP and the Australian Dental Association. So it's both for GPs and for dentists, and it's really about highlighting, I guess, the changing face of head and neck cancer. So the younger women and people being diagnosed with HPV-related head and neck cancers, raising that awareness amongst GPs and dentists so people are picked up early and most importantly referred to a head and neck cancer specialist team so they can get the right treatment as quickly as possible. So I'll send through that link. There is actually the option, even if you don't have an APRA registration number, to do that. And you'll get a certificate on completion. There's also a webinar that we were involved with last year with the Australian Dental Association. You do need to be an ADA member to access it, but I'll send through that link. It included a radiation oncologist and an oral and maxillofacial surgeon talking about head and neck cancer and some of the complications and challenges of treatment. And finally, there is Dental Health Services Victoria has some new resources available on their website. So I will put that all in the email for you. But look, thank you all very much for joining. Very special thank you again to Amanda, Sharon and Jen for joining and sharing your expertise and advice. We're really grateful. Thank you everyone for your questions. Sorry if we didn't get to all of your questions. The next time we'll have to allow just a little bit more time. But thank you all. I hope you enjoyed it. And there will also be a survey, a short survey that we send around after the webinar. So please give us your feedback so we can continue improving and offering topics that you'll find useful. Thanks everyone. Have a great day. Bye-bye.